Hello, my name is Richard Fielding. I'm an honorary professor in the School of Public Health at the University of Hong Kong and currently clinical lead at the Hong Kong Jockey Club Institute of Cancer Care at the University of Hong Kong. I've been very kindly invited to talk to you in your Congress, and I'd like to thank the organizers for inviting me and to wish you good luck and apologize for not being able to be there in person, but I'm sure you understand, given the circumstances in the world today, that it's much better to do it this way than the old way. Although I do regret not being able to meet some of you in person. So what I'm going to do today is talk briefly about distress in chronic illness, and I'm going to talk about it from the point of view of not distress as a sixth vital sign, which I'm sure you all know about, but the idea of distress as a problem to be identified when you've only got limited resources. And the question under those circumstances that most of us face when we work in psycho-oncology is, who would benefit most from my time when I've only got so much time available? How can I get the best value in terms of benefits for the people I see? And that's the sort of background question to what I'm going to talk about today. So I will start with my slide sharing, try to explain what I mean as I go along. I've named this talk a workable psycho-oncology. And I've done that because I think the idea of being cost effective is one that we have to take more and more notice of. Money is going to become less and less available for the provision of services as the numbers of people wanting those services increase and the willingness of governments to fund healthcare decreases. I want to start off by making a point that distress is not unique to cancer. The presence of psychosocial distress in people diagnosed with a variety of life-threatening conditions is comprehensively documented. Cancer is just perhaps one of the big ones because that's the area we work in. But if you look at the literature, you can find that evidence for depression or distress in a range of chronic diseases is very strong. So in coronary heart disease, for example, between 50 and 30% of patients suffer from depression. And of course, at cancers, distress, Zabora's study in 2001 of different distress levels in cancer ranged from 30% for gynecological cancers on average to about 50% for lung cancer, a mean of about 35%. More recently, reviews have indicated that between about 11 and 14% of the general population at any one time have an anxiety condition, and around 3 to 5% of patients have a clinical depression of some degree. And this is in the general population. So against that background, we have to recognize that there is going to be an increased rate of distress in people who encounter an acute or an unexpected chronic condition, such as diagnosis of cancer. Now, this figure here is taken from some work that my colleague Wendy Lam did after her PhD. And we basically were interested in knowing whether or not you could decompose distress in women who had breast cancer and see how different trajectories of distress evolved over time. And you can see that there were basically a low distress group. This is a distress indicator here, measured by the Chinese Health Questionnaire, which is Chinese version of the General Health Questionnaire, which is a GP measure for in the general population of anxiety, depression. And then time along the bottom axis, time after surgery. And you can see that the majority of patients, 2/3 of patients, had relatively low levels of distress persistently throughout the period. 2/3 of these women were not particularly distressed. 1/6 of these women had very high levels of distress that were high to begin with and stayed high throughout the course of the study. The other two groups had a high to low recovery pattern or a low to high to low recovery pattern again. So these are called recovered and delayed recovery patterns. I just want to make the point that this pattern of high, low, and recovering groups is something you find in other distressed populations as well, not just cancer patients. For example, it's a very characteristic pattern that's seen in populations that have been exposed to sudden unexpected trauma, and where you have reactions where the measure of interest is post-traumatic stress disorder, for example, or post-traumatic stress symptomatology. It's seen in reactions to generalized events such as disasters. One of my points I want to make is that this is a generalized pattern that seems to occur across a very wide variety of groups and circumstances. And it seems to tell us something about the vulnerabilities, the groups that are vulnerable in a population and the groups that are not vulnerable in a population. And as I go through my talk, what I want to do is to focus more on the vulnerable group, because these are the ones I believe that our efforts are most likely to be beneficial for. What Wendy Lamb, working with George Bonanno and Anthony Mancini, and I did was that we took that first 8-month period of recovery, distress recovery in that group of women, and we followed them up 6 years later. And what we found was that, not surprisingly, when you think about it, the women who had the highest levels of distress, the ones with chronic distress, had significantly greater long-term cancer-related distress, more psychological distress, and poorer social adjustment in comparison to women in the resilient group. This is not surprising, but it does show you that high chronic stress group stay high. They don't automatically recover. Some of them will show improvements, but not all of them. So let's look at the question, a more general question. Let's back up a bit and think, what are the explanations for sick patients being distressed? Logically, we can identify a number of natural histories, so I call them natural histories. So we have what I call type 1 natural history, and that is, these are people who are fine, they're coping with life, that everything is good, they've got a family, they may be struggling with paying the mortgage or working or getting their kids to eat their dinner. And then they face a diagnosis of cancer. It's out of the blue, it's unexpected. They have transient reaction to this, distress. The treatment is disruptive to their life. Their roles are disrupted. But as the treatment ends, this condition resolves. And very often, very quickly, actually, after the diagnosis, these people settle down into a managing and coping with the diagnosis. These are the 66% resilient group that I showed in the figure previously. As the disease resolves, most patients in this group can get on with their lives. They have a low need for intervention. The second natural history is what I call type 2. This reflects distress arising from the impact of the disease and treatments on how patients feel and function. And this really refers to people who have residual effects. So they may have developed a chronic insomnia, they may have persistent neuropathies, they may suffer from fatigue or possibly pain, although in our experience, the most common symptoms that we encounter with our patients are insomnia, neuropathy and fatigue, followed by weight problems, and pain is actually not a huge problem for most patients. And where it is, it tends to be linked to surgical wound or a related sort of interventional damage that's been done. These people have an expectation of getting back to normality, but it's blocked. They're prevented from returning to their normal roles and being functional by the fact that they have these symptoms, and it's making life very difficult for them. These people have a high need for symptom-targeted intervention. Our philosophy at JCICC is there's no point treating the psychological distress of these patients if you're not going to deal with the underlying blockage that's preventing them from returning to normal. They're distressed because they don't return, so they can't do what they wanted to do, what they were expecting to do, what they were maybe promised they would be able to do, or what they believed they would be able to do once the treatment had finished. They're distressed because of this frustration in achieving their goals. So by targeting the symptoms, these people can be best helped. And very often they don't need psychological intervention. They need help on sleep management, sleep hygiene. They need advice on managing neuropathies. They need help with weight and diet. And that's why our team at JCICC consists of nurses, dietitians, exercise specialists, as well as social workers and psychologists. We specifically target poorly managed symptoms because nobody else in the hospital system is doing that. Patients are told very often, oh, look, you're lucky to be alive. Don't complain because you can't sleep very well. Some people in your condition will be dead. This is a very poor way of managing these kinds of problems. But this is very important. These people are curable. This is a preventable state of affairs that can be dealt with. Type 3 natural history refers to the people with the background prevalence of pre-existing mental health issues. And that's somewhere between 10 and 20%, about 15% in Wendy Lamb's studies. They were distressed. These are people who are distressed before they get sick. They're often people who lack long-term coping skills. About 3 years ago, a paper by Stanton in the US looked at adversity in childhood as a predictor of distress, and she found that it was a very strong predictor of certain types of persistent distress. So this is a very important point to bear in mind, that there are people who have had distress before they had cancer, who also got cancer. And it's a mistake on our part to attribute their distress to having cancer. Very often it pre-existed. And a lot of these people have already got links to the mental health care system. They may be seeing a psychiatrist or have been seen by a psychologist. They may be on psychotropic medication already. Type 4 natural history is for people who are distressed by the sort of existential questions that come after a diagnosis of cancer. People who may have been very devout religious people suddenly find themselves questioning their faith. How I've been, I've done all the right things, I've done everything, I've been a good Christian, how come now I'm being, why do I feel I'm being punished for this? People who may have fear of recurrence, what if this comes back? What if I die? What if I have to go through all this again? Emergent relationship issues. Oh, this has really woken me up to the fact that I can't take life for granted. Do I really want to spend the rest of my life with this person who I married 20 years ago, but really, I don't really enjoy very much anymore, but I tolerate just now? So these kinds of people have a variable needs. Some of them have a need for help sometimes, at other times they don't. So the biggest question is, how do we identify the patients, that 15% of patients who are going to have persistent distress? Most of these people will be in the type 3 trajectory, but not all of them. There are others in type 2 and then elsewhere if they're not properly managed. So the best care is coordinated, integrated, holistic, but rare care. Psycho-oncologists seek to improve the psychological well-being of cancer patients by screening for distress, finding distress, treating distress, depression, PTSD, fear of recurrence. But we tend to ignore the things patients are bothered by. These are unresolved or residual symptoms and late effects, what we call type 2 distress, the kinds of symptoms I outlined that precipitate psychological reactions, and failing to address these results in poor adherence, high treatment dropout, and dissatisfaction with care. Very often, no one in the healthcare team addresses these causes because it's often easier or cheaper to give a pill or to say that it's psychological and refer to psycho-oncology and wash your hands of it. So the challenge for psycho-oncology, or one of the challenges for psycho-oncology as I see in relation to distress, is not simply to identify distressed patients, because most people at some point will be distressed by the experience of going through cancer. But most of those people will recover from that without the need for professional help. The problem is, how do we differentiate the patient who will be persistently distressed and intervene to prevent that persistent distress from becoming established? Here I want to go a bit more into work that my colleagues Wendy Lam and Daniela have done on trying to look more carefully at the question of persistent distress. And what they seem to be identifying is this, not unsurprisingly, it's a question of maladaptation. So Wendy and Daniela examine cognitive bias in relation to persistent distress in breast cancer patients. If you're familiar with the cognitive bias literature, you know that there's quite a lot of work that's been done to try and identify the underlying cognitive dimensions of anxiety and other negative emotional states. Wendy and Daniela did 2 studies. One, they compared persistent distress groups with low distress groups of breast cancer patients, identified from a prior study, the one that I showed you. Then the second study examined if cognitive bias is specific for cancer threat or generalized and compared high and low distress cancer and non-cancer patients with cancer threat and neutral words. So they used a sort of a classic cognitive study using dot probe tests. Just a quick background on cognitive theories of emotional disorders. So the idea is that threat-related information may be biased at pre-conscious or conscious levels of processing. That is, the reason why people are anxious is because they are differentially targeting threat-related information, and focus on that maintains a high level of alertness in the organism. This biased processing at pre-conscious or conscious levels may underpin enhanced vulnerability to anxiety and distress. So not surprising, there's been a lot of work done on this, but it's still a little bit, it's not been done clearly in cancer. There are a few studies, but they are not being very well done. Most of the work has been done on generalized anxiety disorder. Prior research has found that anxious people show automatic pre-conscious allocation of attention towards threat-related stimuli, followed by later, after about 1,000 milliseconds, a conscious avoidance away from such threat-related information. So it's almost like quick look, identify threat, then having identified it, make the decision to having identified it automatically, make the conscious decision to ignore it or avoid it. So this is, you think of as a basic emotional avoidance strategy. And this links into the transactional model of stress. Now, you probably all know this, but I just very quickly recap over it. So the transactional model of stress posits that threat assessment occurs at the primary appraisal level. And that might be considered to be the estimate between perceived resources and perceived demands. The primary appraisal presents a map for coping. There is a threat. The threat is then presented to the coping solutions that are available. If the threat is identified, the coping response targets the threat, and that's the problem-focused coping. We try to do something about it to remove the threat, or if you cannot do something about it, as in the case of, say, cancer, where you can't fix the problem, then you manage the emotional responses to the threat. That's the best you can do. Coping effective evaluation then takes place, and that is, did my strategy for managing the threat work? That's called secondary appraisal. So the idea here is that because the threat cannot be avoided, the responses are going to be emotional focused responses. Now, there is the difference between high distress and low distress people, or chronic distress and resilient people, one of a differential bias in perceptual processing brought about by either habitual sensitivity to threat or low tolerance of threat or something else. So the hypothesis that was tested is that cancer words, but not negative words, would prompt greater avoidance in distress than non-distress cancer patients, but not others. For example, those with generalized health anxiety. Two papers came out of this, one on the role of cognitive bias in relation to persistent distress among women diagnosed with breast cancer. And this was a dot probe task and an ambiguous cues task. An ambiguous cues task is where words that can have two meanings are presented, and then you look at the response time to these words. Those words that are where the ambiguity of meaning interferes with the person's response time indicate that the person is maybe more sensitive to the alternative meaning of the word than the implied meaning of the word, which is more often a neutral condition. And the study assessed bias towards cancer-related and neutral information in 140 women after breast cancer surgery. There was no automatic allocation seen towards the threat-related words in preference to neutral words on the dot probe task. But there was a supraliminal, that is, there was a conscious allocation of attention away from cancer-related words in the more distressed group. So the more distressed group were avoiding more anything to do with the idea of cancer. The study concluded that women reporting persistent anxiety may have a tendency to negatively interpret ambiguous information and leading to illness preoccupation. The second study came out last year on how generalized conscious attentional avoidance in response to threat was. And this compared supraliminal attentional avoidance between high and low anxiety, breast cancer and non-cancer participants. And what was found was that the breast cancer women avoided non-cancer words. The breast cancer women avoided, but the non-cancer women attended to negative valence words, general negative valence words, such as, for example, pain or distress. But all high anxiety women directed attention away from cancer-related words, indicating some non-specificity of cancer threat avoidance and exaggerated threat avoidance generally. 32 women. Some with low and high anxiety and some low and high depression. There was no evidence that that attentional bias differentiated between low and high depression or breast cancer and control groups. There were no differences in those 4 groups. The differences occurred in the anxiety groups. So using an experimental task where a congruent event was a fixation point followed by a prime and a neutral prime or a target prime, a masking, and then the target word, neutral word, and then the probe. So move quickly on to the results. For negatively valence words, we just looked at conscious avoidance, and you can see that there was a significant main effect for groups and an interaction that was borderline. So the low anxiety cancer patients tended to attend more to negative valence words, as did the other groups, apart from the healthy low anxiety groups who didn't really change at all on any of the measures. The high anxiety groups were particularly attentive to that. But the cancer high anxiety group are avoidant of those words. When we look at cancer-related words, we see that both high anxiety groups were avoidant, but the cancer low anxiety group was attentive. So these, another model that appears relevant here is Suzanne Miller's minimax hypothesis, the idea that some people are, when they're in a situation of threat, they tend to respond in one of 2 styles. One is that they become information seekers. They want to know as much as possible about the threat, and others become information avoiders. They want to minimize the amount of information. These are all potentially relevant hypotheses that might have a bearing to explain this kind of result. This is a sum of the previous 2 graphs I've just shown you, and you can see that the difference in the health anxious people is different to that in the anxious breast cancer patients. So these are non-cancer patients. These are healthy controls. These are breast cancer. You can see there's a very different response to whether the words were negative words or cancer words, whereas for breast cancer patients, avoidance is more generalized. Non-anxious breast cancer patients tend to be more focused on information. The other group don't show any responses. So what does that interpretation mean? Well, I think threat perceived by distressed women recovering from cancer generalizes. It's not specific just to cancer. They become more distressed, and it may be that the reason for this is that cancer is not the primary reason for their distress. It may be that these are people who are poor copers themselves. There does not seem to be a characteristic bias in information processing that differs significantly from generalized anxiety. Now, I want to come back to talk very briefly about some other work before I finish. I just want to talk about a Dutch study. They looked at the persistence of stability of fear of cancer recurrence over a 12-month period. And for each month, they asked patients to record, 377 patients to record their level of fear of cancer recurrence. There were 3 groups. One group had high stable fear of recurrence, one group had low stable fear of recurrence, and the majority fluctuated between high and low depending on certain events. And those events or triggers were medical appointments, experiencing symptoms or feeling unwell, or most commonly, some sort of negative related event to do with health, such as obituaries in the newspaper, funerals, news, conversations about or hearing about other people's illnesses. Almost 60% had fluctuating levels of fear of cancer recurrence. 20% reported stable high and 20% stable low fear of cancer recurrence. Now, I think there's a similarity between this and the first figure I showed you. Variability in fear of cancer recurrence scores seem to be characterized by the way survivors respond to triggers of fear of cancer recurrence, as triggers were more commonly reported by women who experienced high fear of recurrence at all time points, and those with fluctuating levels of fear of recurrence. High FCR is characterized by high levels of preoccupation and being less able to respond to triggers in an adaptive way. Although the fluctuating group also pays attention to triggers, they seem better able to adapt to and normalize a company. Women with low FCR at all time points spontaneously reported fewer triggers of FCR, possibly due to less exposure to triggers, paying less attention to triggers, or finding them less bothersome. Finally, they say younger patients, higher educated patients, and those less satisfied with the medical treatment were more likely to belong to the moderate declining or high stable trajectories. These predictors are in line with the view of Simard et al., showing moderate to strong evidence for poor healthcare satisfaction and younger age as predictors for fear of cancer recurrence. Finding on education as a predictor of fear of cancer recurrence remains inconclusive. The high stable group also have the highest proportion of women with children. So in conclusion, optimizing care, good communications, decisional support. We found that having no support in making a treatment decision early on was a reason for a higher level of distress in breast cancer patients. Addressing symptom need, facilitating achievement of normality, expectations are critical in preventing much distress in chronic illness. So the hypothesis that stands now is potential persistent distress best identified by markers of early life adversity, symptom persistence, and service dissatisfaction among younger patients with kids? Are these features characteristic of patients who go on to have high persistent levels of distress? And if so, if we can describe these people, we can identify them and we can target them. And we can focus in on helping these patients who would probably benefit most from our time. That's the end of my talk. Thank you once again to the organizers, and goodbye.